important topics and really common topics as well. So I think we're really thankful for that because it kind of helps us understand a lot of these disorders and diseases from a really clinical standpoint of view and also understand some interesting and new facts on this as well. And you can actually share your slides as well after while we're presenting, and you can share the screen for your slides as well.
Perfect.
I haven't heard a lot of details or info regarding this, so thank you so much for that.
Right, Catherine, 2 seconds. I actually wanted to, I just very quickly looked at who you gave, and also, those are 100% existing issues of papers. I looked at a couple of different papers, including actually I'll pin one that suggested that protein sources, whether or not it was animal or vegetable-based proteins, might matter. You discussed briefly the amino, or I think it was Sean that discussed briefly about specific amino acids. Could you talk about that a little bit more?
About which amino acids that the paper was looking into or measuring?
Yeah, I just trying to understand this on my side.
So the paper made a point to point out that with a high protein intake, that it was found to induce a mild metabolic acidosis. I'm not sure exactly what they meant by that. It might be just due to increased circulating amino acids, but they focused specifically on glutamine and how this mild acidosis would prevent the body from producing its own glutamine from its own liver stores, and then they were going on about how that would affect a lot of immunological processes like producing interleukin-2, which is an antiviral cytokine. Now that was in a in vitro study, so in a what's called a petri dish, basically. And I don't know if that's actually what happens in the human body.
Thank you so much, Sean, for that explanation. It was a great discussion, guys. And now the show is about to begin. Dr. Anuradha is going to speak to us. So over to you, Ms. Khan.
Hello, and welcome to MedNews Week Conference, where our goal is to bring you the most cutting-edge medical information from medicine's global leaders. I am Muskan Joshi, and I will be your host for today. Before we begin, I want to first acknowledge the great team that helps us make these events a reality. Our founders are two internationally recognized researchers, Dr. Jan Leifman and Dr. Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Dr. Jan Leifman, Dr. Park, and Pratisha Ghanta. Our organizing committee is comprised of Alexandra Van de Keer and Dr. Yabu Sile. Our managers include William Wilkerson, myself, Muskan Joshi, Pallavi Pai, and Gayatri Menon. Our educational committee includes Sean Jakevitz, Shubha Pawar, Janvi Shah, Madhuri Balasubramaniam, and Chaurya Harshad. We would also like to thank our partners, Medi, who are global leaders in medical video educational content, and the National Society of High Schoolers, an honor society founded by the Claes Nobel of the Nobel Prize family. The moderator for today's event is Gayatri Menon. And now to introduce our keynote speaker for today, Dr. Lala-Trindade. She is an internationally recognized authority and researcher in heart failure and has received numerous international and national awards, including the ACC Emerging Faculty Leadership Academy Award in 2019, selected for the CTSA-funded Mount Sinai LEAD program for the leadership development training for junior faculty, which was a year-long program in 2018. The AHA Young Professionals Honorary and in 2016, and the Young Heart Award in 2016. Dr. Lala-Trindade currently serves as the Associate Director of the American Heart Association Fellow Society of the Greater New York Area and also the Task Force Co-Chair as part of the Associate Clinical Leadership and the Data Coordinating Center for the NHLBI Cardiothoracic Surgical Trials Network. She is also the Program Director of the Advanced Heart Failure and Transplant Fellowship and Director of Heart Failure Research at the Zena and Michael A. Wiener Cardiovascular Institute, Department of Population Health Science, and is the Associate Professor of Medicine, Cardiology, and Population Health Science and Policy at the Icahn School of Medicine at Mount Sinai. With that, it is my pleasure to welcome Dr. Lala-Trindade. The floor is all yours.
Well, thank you so much. It's such an honor and privilege to be here tonight with you all. I think this is such a new and fun, exciting forum to discuss relevant new scientific information and content. I'll try and go over this topic, which is transitions in care for acute heart failure, the power to influence outcomes, to the best of my abilities. And I'm focusing mainly on this transitions in care aspect of this subject because I think it doesn't get enough information or enough attention rather. So thanks for the very kind introduction. And without further ado, I'll get started. These are my relevant disclosures. And so over the next 40 minutes or so, I just want to go over what is acute heart failure. We think we know it, but do we really? So let's go over the precise definitions and how it applies. The associated vulnerability of this transitions in care phase, or this acute heart failure hospitalization phase, the components of transitions in care, what actually works to improve outcomes, and then finally end on something that's very near and dear to my heart, which is how do words matter when we speak to our patients and speak about these subject matters. So let's start first with what is acute heart failure. So if we look at the new universal definition of heart failure, which was published in the Journal of Cardiac Failure, as well as the new heart failure guidelines published in JCF, JACC, and CIRC last year, we have to realize that there's a huge emphasis on the fact that heart failure is a clinical syndrome. So we can never forget that. So that's constituted by the symptoms and or signs of heart failure caused by a structural and or functional cardiac abnormality that is now, this is the important distinction, it's corroborated by one of the following: elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion. So you knew the symptoms and signs before, but now they have to be corroborated by those objective evidence factors of congestion. So what is congestion? We hear that all the time. What does that actually mean? Well, I think of it like around this paradigm, which is there's some abnormal LV function, systolic or diastolic, and this is grossly simplified. I'm not talking about the RV dysfunction at all here, but there's abnormal LV, systolic and diastolic dysfunction, and then there's some trigger. Now, the trigger can be diet, it can be medications, it can be non-compliance, it can be infection, ischemia, arrhythmia, hypertension, endocrine, whatever it may be. You need that trigger that sets the patient off. And that leads to impaired volume regulation. And what do we mean by that? Well, behind the scenes, you're seeing increased renin-angiotensin-aldosterone system activation, reduced cardiac output in certain cases, endothelial activation, inflammation, adenosine signaling, and then fluid redistribution, right? That's the key here. It's a redistribution of fluid. And so then what do we see? We see an increase in intracardiac filling pressures. We see an increase in LA and wedge pressure. We see an increase in pulmonary pressures, and we see an increase in right-sided pressures, all of which cause our patients to present with symptoms, right? So that's a little bit about congestion. Let's break it down further. What is clinical congestion? So we're all familiar with the signs of congestion, right? Elevated jugular venous pressure, edema, pleural effusions, pulmonary edema on X-ray or Rales, ascites, elevated natriuretic peptides like we talked about. But that's not what the patient feels, right? The patient feels the symptoms. That's not what's bringing them into the ER. And so if we talk about the symptoms of heart failure, we talk about dyspnea, we talk about fatigue, we talk about early satiety, nausea, edema, bendopnea, right? So that's clinical congestion, is just to go over it again, signs and symptoms. That's what you're seeing when you see that patient. Hemodynamic congestion, on the other hand, precedes clinical congestion by days to weeks and can actually persist after a relief of those symptoms. So what do I mean? Let's take an example here. On the left, you see an example of a right heart catheterization done in someone who is still quote unquote congested. So the RA pressure is 15, the RV is 45/15, the LA pressure is 30. Okay, so now what we do is we decongest this patient either by diuretics or a combination of therapies. And what do we see? We don't do this often, but let's say this is a hypothetical example. Now the RA is 8 and the LA pressure is 16. Okay. What does the patient tell us? The patient says, listen, I don't have shortness of breath anymore. I want to get out of this hospital. I feel better. I want to go home. But what we don't realize is that, yes, they feel better at rest, but what happens to them with exercise? What happens to them when they go home and they start eating their normal diet again? That LA pressure that's at 16 now is still elevated, and it's very easy for it to tip over for it to be a problematic elevation in intracardiac pressures once again. So when we talk about congestion and we want to specifically zone in on what acute decompensated heart failure is, let's try and put this all in context. So we already talked about the definition of heart failure, right? We talked about this need for congestion, right, on the side here. But really what we're talking about in the acute setting is that now these signs and symptoms are refractory to standard therapy, and they require an escalation of therapy. That's a very, very important point here. So in the acute setting, they're refractory to standard therapy, and they require an escalation of therapy. And that's what denotes acute decompensated heart failure. Okay, so we've done some definitions. Let's go on to the associated vulnerability of the post-acute heart failure phase. Okay, what is the burden? Specifically, we often refer to this period as after heart failure hospitalization. So we all know that heart failure hospitalizations constitute over 1 million admissions per year. We know that it's a major cause for morbidity and mortality. In fact, 1 in 6 die within 30 days of hospitalization for acute heart failure. The in-hospital mortality alone is 4 to 7%. Importantly, the number of decompensation events predicts mortality independent of one's age and or renal function. And finally, the costs, of course, as one would imagine, are astronomical, upwards of $30 to $40 billion in the US alone per year. So we often have this paradigm in mind, right? Patient gets hospitalized for heart failure, they're discharged, and then we want to transcend them into chronic heart failure. But this vulnerable phase is thought of right here, right? And we think of this transitions in care period as around here, right? And we're going to talk a little bit about why we might need to think about that earlier on in the game. So not only is mortality high, but of course, rehospitalization is very high in that early phase after hospitalization. Within 30 days, 1 in 4 is readmitted. Within 6 months, 1 in 2 is readmitted. So that's pretty crazy if you think about it from your family's perspective. I always say this to our fellows, you know, what if God forbid, your family member was hospitalized for heart failure and they say, gosh, what's the chance of me being rehospitalized in a month, in 6 months? For you to say 25 and then 50% respectively, that's a big jolt. That would make someone feel quite insecure and quite frankly scared. So what's the point? Why are readmissions so important? Well, we all know that they're incredibly important for hospital metrics, right? They decrease our hospital metrics, they decrease patient satisfaction, they increase clinician burnout, right? And they, of course, as we already said, have a very tight correlation with adverse outcomes. So what is our goal? Our goal is to reduce readmissions and increase patient quality of life and, of course, quantity of life. Okay, so we've talked about that vulnerable sort of what terrible outcomes are associated with this post-hospitalization or post-acute heart failure phase. Now let's get into the nitty-gritty. What are the components of the transitions in care? So in hospital, pre-discharge and post-discharge. And I think we oftentimes think of really just this pre-discharge and post-discharge phase. What I'm going to argue today is that it's the in-hospital phase that's actually the most important of all of these three. Even though we don't typically think of it as a transition period, that's when we need to start thinking about this. So What are some of the things we can do in the hospital to ensure that our patients are best treated? Well, one, we need to optimize medical therapy. We know that, right? So the question we need to pose to ourselves is not, oh, should I put this patient on an ACE/ARB/ARNI? Should I put this person on an SGLT2 inhibitor? No, it needs to be, why is this patient not on an ARNI? Why is this patient not on an evidence-based beta blocker? Why is this patient not on a mineralocorticoid receptor antagonist? Why is this patient not on an SGLT2 inhibitor? And then other therapies come into play like digoxin, hydralazine, isosorbide, and others. But really, that's the question we need to ask ourselves. Then we need to think about comorbid conditions. You know, it's not just that they're here for heart failure. What about their coronary disease? Has that been looked at? Has it been properly treated? What about their atrial fibrillation? Are they rate controlled? Do they warrant a try at rhythm control? What about their obstructive sleep apnea? Are they using CPAP or BiPAP? Is it adequately controlled? What about obesity, asthma, diabetes, CKD? All of these things play into the constellation that forms that heart failure patient. So really important to address those comorbid conditions in hospital. And then, of course, the mainstay of therapy, as everyone is very well aware, is the decongestion aspect of it. But I would say we need to push it a little further. Just like I showed you that hypothetical example of a patient who feels well and is at rest, what we need to do is push it, right? So do our patients have edema, JVD? So not just their symptoms, but do they have any signs still that are residual after decongestive therapies? Are they tolerating stable doses of oral diuretics? Most importantly, are they orthopnic? Okay, do we lie that head of the bed flat? Do we walk our patients around the halls? And I think that's the kind of a provocative symptom stress test that we need to do to ensure that our patients are indeed adequately decongested, if not, at least not needing advanced therapies or other therapies. And then maybe even most important is the getting to know you, right? Why is your patient here? Do we know what was that trigger? Did they know what the trigger was? What was that trigger? What are the barriers to adherence, right? That is so crucial. Maybe coming from New York, I see this very frequently where we see patients, described as being non-adherent or non-compliant all too frequently, and perhaps unreasonably so. So this is a paper that Rob Mentz, a dear friend, colleague, and the editor-in-chief of JCF, and I wrote together, where we talk about this commonly encountered HPI, right? And a 47-year-old man is admitted with acute heart failure in the setting of medication non-adherence or non-compliance. But what if we took that around, right? This immediately causes this defensiveness between me and the patient. Oh, why didn't you take your meds? Oh, you're never going to take them anyway. Why should I bother? That type of apathy and kind of cynicism creeps in. Whereas if we change this narrative and we said a 47-year-old man is admitted with acute heart failure, potential barriers to adherence include cost and polypharmacy in the setting of recent job loss. Think about what a different reframing of this story is provided with this information, right? Immediately you feel sympathy or empathy for this patient. You think about how they can help them cross those barriers of cost and polypharmacy. You try to consolidate their medicines. You try to get them coupons for what they can't necessarily afford. Okay, so we talked about those in-hospital imperatives. Now let's talk about that pre-discharge phase. So one, education, crucially important, right? Education on diet, importance of medications. What actually is heart failure? Meeting patients at their level, at their health literacy level, crucially important. What about medication review and reconciliation? Have we gone over any changes that were made from their pre-admission medication list to now their discharge list? Ensure that the pharmacy is correct. Ensure that there is feasibility of picking up their medicines from that pharmacy on discharge. What about their follow-up appointments? Do they have transportation arranged for those appointments? Is it reasonable or feasible to expect them to show up to them? Have you had communication with their ambulatory providers, both cardiovascular and non-cardiovascular? And then finally, we need to ensure that that discharge summary is really, really a very effective communication tool. It allows us to express the outcome of the hospitalization, the patient's disposition and expectation moving forward, and then the provisions that have been made for follow-up. So I insert this here because we talk a lot, and you saw on this preceding slide where we talk about communication with ambulatory providers, right? And so oftentimes we talk about multidisciplinary collaborations and communication for our patients, but what we don't often recognize is the fact that a given heart failure patient or patient living with heart failure will see up to 3, sometimes 4, or even 5 different cardiovascular specialists, whether it's an imager, a cardiothoracic surgeon, electrophysiology or interventional cardiologist, and their heart failure specialist with their primary care provider. And so this schematic that we put together amongst a number of colleagues and myself a couple of years ago now really just illustrates that you need quote unquote frontline providers even in the outpatient setting. So once a patient is designated as having heart failure, that lies between the heart failure specialists and the primary cardiology provider, whose then responsibility it is to coordinate care amongst all the different specialists that you see here. So before we have multidisciplinary collaboration, we need to have intradisciplinary collaboration and communication. Okay, so now we're into that post-discharge phase. What are the components of this? Well, some of the things that have been studied include telephone follow-up, education, self-management, weight monitoring, sodium and dietary advice, exercise recommendations, medication review, and social and psychological support, all of which really at the end of the day are about patient empowerment. Can we empower our patients to care for themselves with support, education, resources? Though none of these individual components led to an improvement in outcome, really up to date, what we've seen is it's the multifaceted, multidisciplinary interventions, including potential for home visits by nursing, that are focused on the patient's context and the patient's capacity that lead to a reduction in readmissions and have a better health system value. Okay, so now we've talked about what heart failure is, what acute heart failure is, right? That refractory to medical therapy, that's standard, as well as a requirement for escalation of therapy. We've talked about the vulnerability of that post-acute heart failure phase with high rates of mortality and readmission. Then we've talked about the components of transition and care and how it really starts in hospital as opposed to pre-discharge. Now we're going to focus on what actually works. What can we do to make a difference? Okay, so let's go through some data. That's my favorite approach to doing things. So rapid follow-up appointments, right? This is a nice study done by Harriet Banspell a couple of years ago now called PACT-HF, where what she did is she took a multi-pronged approach to transitions in care and tested it against usual care. And so that comprised of nurse-led self-care education, a structured hospital discharge summary, a family physician follow-up appointment within 7 days, and structured nurse home visits and heart function clinic care in any high-risk patient. So you can see here, it's almost 2,500 patients with heart failure, right? And they're randomized to the transitional and care program or usual care. And unfortunately, at the end of 3 months, there was no significant difference in the primary outcome of the composite of all-cause readmission, emergency room visits, or death, okay? The hazard ratio was 0.99, so really no difference, overlapping Kaplan-Meier curves. However, if you just looked at all-cause readmission or ED visits, okay, and you didn't look at death, again, which is not, necessarily as common in this endpoint, the hazard ratio was 0.93, and it was statistically significant. Importantly, in terms of secondary outcomes, you can see there was a difference of 2.65 in the mean Be Prepared score. What is this? A Be Prepared score is a patient-reported measure of preparedness for discharge. Now, you might say, well, who cares really about that? But that translates into better patient experience, right? And there's so much emphasis on that. There's better quality of life associated with with higher patient experience levels. And so what we might want to think about then is that it's not just survival that we need to take into account, but also the quality of life, right? And it's interesting, in a subsequent paper done by Vanessa Bloomer and colleagues with Dr. Banspell, what they saw was there was actually a differences based on sex in terms of quality of life, not necessarily these clinical outcomes, but a quality of life that was improved for women, but not necessarily men. So there may be a difference there too. Okay, so let's look at some more data. This data comes out of the Kaiser Permanente group. where they looked at a heart failure transition care program, okay, in over 26,000 patients. This is over a 10-year period. And what that comprised of was a home health or a telephone visit within 2 days of discharge, heart failure care manager call within 7 days, and a physician or NP visit within 7 days. So pretty robust. And Kaiser is able to do this because they have such an integrated health system. And so look again, no difference in the 30-day all-cause inpatient and observation stay readmission risk. Okay, so readmission here. Now, let's look at the individual components. Was it the telecare versus no telecare? No. Was it this home health visit versus none? No. Was it the telecare visit at 2 days? No. Was it the 7-day phone call? No. But the difference that we did see was the 7-day clinic visit versus no clinic visit. Regardless of who it was, there was a statistically significant difference in that 30-day endpoint of reducing readmissions, which is why it's in the guidelines now, which is why at Sinai, for example, all patients within a primary diagnosis of acute heart failure will be given a rapid follow-up appointment within 7 days of discharge. Whether they come or not is a different story, but that is what we routinely do. Okay, so we've shown some not so great data on interventions that might work to prevent readmissions, certainly not death, but maybe quality of life may be improved. But what actually really works? What can make a huge difference? So again, this is where we back it up a little bit and we talk about that in-hospital phase of the transitions in care. So in-hospital decongestion works. Very important. And I'll show you some data to this effect. The initiation and optimization of medications work. These are data that have been adapted from Greg Fonaro's work and Steve Green's work, as well as others, where it just shows you, we all go through this, where we're like, you know what? I'm not going to start my beta blocker here on this patient now. I'll just start it as an outpatient. And then something happens and they don't get started on it for whatever reason. So these data are just showing us that when we initiate the medications in-house, meaning while they're a captive audience in the hospital, the likelihood that they'll be on these medications at 60 to 90-day follow-up is astronomically higher than if we initiated or if they're not prescribed those medications on hospital discharge, right? So pushing it past that to the next clinic follow-up visit is not the right way to do things. So what about that congestion I was telling you about? So many patients are still discharged with congestion, which is kind of mind-blowing if you think about it, but it, on the other hand, isn't, because we've never gotten perfectly equipped to really evaluate how to measure congestion and decongestion. But these are data I put together with several colleagues of mine, now older, but still relevant, because this applies to the DOSE and the CAREST trials, which are aimed primarily on decongestion. And what we saw is that when we looked at the combination of orthopnea and edema, or otherwise acutely phrased orthedema, only 50% went home without that. If you think about it, that's crazy, right? Only 50% at these hospital centers, which are Duke, Mayo Clinic, Brigham and Women's Hospital, WashU, Cleveland Clinic, et cetera. Only 50% were going home without 2+ orthopnea and or 2+ pitting edema. That's pretty astonishing to me. And of those folks who did go home without those symptoms, look at this. At 60 days, almost 40% had high-grade orthedema right afterwards, and another 27% had low-grade orthedema, meaning they had 1+ edema and orthopnea. So not only is not enough people going home decongested, but then of those who are going home decongested, a lot of them are reaccumulating within 60 days or even sometimes sooner. Then I would just say that it's important for us to recognize that the congestion levels actually are correlating and have correlated in a number of studies now with clinical endpoints. So look at this. So these are the orthedema scores. You can see here, these are the sort of in between and the 1 to 2+ orthedema scores, higher rates of readmission, death, or unscheduled visit composite compared to those patients without congestion. And then if you look at people with high-grade congestion, meaning significant orthopnea and significant edema, very, very high rates of clinical adverse outcomes, right? So again, high combined endpoint of death, rehospitalization, or unscheduled visits. So decongestion is key. That really, really is so important. Okay, so I've shown you all of this, but how can we prevent it? If I'm saying we're not that good at telling what it is and when we've adequately decongested it, then how can we prevent it? And this is a therapy that I think has revolutionized the care of patients living with heart failure, which is commonly known as the CardioMEMS device, but otherwise broadly is known as a PA pressure sensor monitoring device. And they're more than just the CardioMEMS device now under investigation. And so really the theory behind this is, or the rationale rather, is that filling pressures rise in the intracardiac setting to a critical threshold, at which point decompensation occurs. And so the idea is, can we catch patients before that critical threshold to prevent that hospitalization and decompensation? So I'm a big proponent, just to end on that. I think the data of GUIDE-HF are also equally convincing, and I think that this is an underutilized therapy. Okay, so what about some newer data? Okay. Previously, prior to 2019, almost every clinical trial we did in acute heart failure was a negative study, meaning it did not show a clinical benefit for patients who were hospitalized for acute heart failure. Then came PIONEER, right, which was the study of sacubitril valsartan in heart failure with reduced ejection fraction patients who were hospitalized for heart failure, and it showed an astronomical difference. And I'll go through some of these data quickly, but it was followed by Victoria, Galactic, Soloist, Impulse, Affirm, Transform, and ADVOR, all of which have been super exciting and honestly only within the past 1 to 2 years. So it's a great time to enter the field of heart failure for the trainees who are listening tonight. I already told you about sacubitril valsartan in heart failure with reduced ejection fraction. Just look at this. I mean, the percent change from baseline of NT-proBNP levels was the primary endpoint because it's a surrogate for clinical outcomes. And look at this, it's a 29% greater reduction with sacubitril valsartan compared to enalapril, also a very efficacious drug. When you look at clinical outcomes, which this trial was not powered to do, very significant difference, very, very significant difference. A, pointing out the instrumental role that NT-proBNP plays in understanding changes for outcomes, and B, showing that it can serve as that surrogate. So even though it wasn't powered to look at this, clinical endpoints improved dramatically, which makes it a class 1 actually to have our patients with heart failure in the acute setting to be offered an angiotensin receptor neprilysin inhibitor. Okay, Victoria. Victoria was a study of vericiguat in heart failure with reduced ejection fraction and a recent worsening heart failure event. And so what is vericiguat? Vericiguat is a soluble guanylate cyclase stimulator, and it works a little bit differently than riociguat, for those of you who have heard of that, does. And so they tested this drug compared to placebo. These patients were largely optimized on guideline-directed medical therapy, but remember, at the time that this was conducted, it did not involve SGLT2 inhibitors, and it really, ARNIs were not still mainstay of therapy. And what they saw is at a median of about 11 months, there was a modest decreased cumulative incidence of the combination of cardiovascular death or heart failure hospitalization. So relative risk reduction of about 10%. What they noted in sub-hoc analyses, or post-hoc analyses rather, was that there might have been a larger effect in those patients with whom we saw an NT-proBNP less than 8,000. And we saw a greater benefit amongst those patients who seemed to be further out from a recent worsening heart failure event, which has now led its way to the design and now conduct of the VICTOR study, which is being studied exactly in this population. So what about omecamtiv mecarbil? This has gotten a lot of press recently with the FDA commenting on it. So omecamtiv mecarbil, as most of you may know, is a cardiac myosin activator. So basically you think about it as one that stabilizes myosin in a pre-primed position. So it increases the number of myosin heads that are available for contraction. And the analogy that's beautifully used by John Teerlink and others is that there are more hands on a rope that lead to a more forceful contraction and a winning of that tug of war. Interestingly enough, in this trial, 25% were inpatient, because you might be saying, why is she bringing this up? We're talking about acute heart failure. 25% of this population, and it was an 8,000 person trial, were inpatient. So that's important to recognize. And we should also see that there was a potentially larger effect with those patients who had more advanced disease, lower ejection fraction, higher symptom burden, higher BNP, lower blood pressure. And so quite frankly, we were excited about this becoming available for our patients who are in between advanced therapies and advanced heart failure. But more remains to be seen because the FDA advisory board certainly was not favorable. Okay, what about Soloist? All right, we've done Pioneer, now we've done Galactic, and now we're doing Soloist. So Soloist was done by Dr. Bhatt, who is now my boss at Mount Sinai Hospital. And what you see here is this was a randomized study of sotagliflozin versus placebo. And this is the key point here, is that everybody had diabetes, everybody had heart failure, but the ejection fraction did not matter. So it included both HFpEF and HFrEF. And it included, this is also super important, which is why it's a part of this trial, is that 48% were inpatient. So only 52% were outpatient, obviously. And what they found was, and I think this is remarkable, so about 600 plus in each group, what we saw was that it was very significant results across the gamut. So across the primary outcome of heart failure urgent visits, heart failure hospitalizations, and cardiovascular death. And then when you break it up, which is often done, you can see that it was driven by a reduction in heart failure hospitalizations or urgent visits, which is not too surprising to me. So conclusion is that among patients with diabetes and heart failure, regardless of ejection fraction, they should be on SGLT2 inhibitors. We can talk a little bit about whether they should be on sotagliflozin versus another one, but this is nonetheless what the study showed. Okay, so what about the other SGLT2 inhibitors? So this was MPulse. This was published last year and around the time of AHA. And so I think this is a beautiful study because it was a smaller number of patients than typically is seen in a cardiovascular trial. And it was, the N was only 530, but this again included across the range of ejection fraction. But it also now, the stipulation here is that it didn't matter whether you had diabetes or not, everybody was included, okay? And they analyzed their results in a very interesting methodologic way, which was utilizing the ratio of clinical benefit, or the win ratio. And so it's a hierarchical endpoint wherein you've got to stay alive, right? And in order to be rehospitalized. And if you were rehospitalized, then how much time were you home before you got rehospitalized, right? Similarly, previously to that is if you did die, what was the time to death, right? And then of course, looking at quality of life metrics is very important as well. And so, but you're not going to assess quality of life unless a patient is A, alive, and B, across some of these other hierarchical endpoints. And so what they found was a statistically significant difference across the board. And it's pretty remarkable. So a reduction in death, a reduction in heart failure events, a change in KCCQ that was really near clinically significant. We typically consider 5 points being significant. This was 4.5, so very, very close. No difference in acute renal failure, also important, and oftentimes the cause of contention amongst practitioners and also fear for patients. And then body weight change was also significant. You can see 1.5 kilograms in AMPA versus placebo. Okay, moving right along, just in the interest of time, we have AFFIRM-HF, which was IV iron in acute heart failure patients with a low ejection fraction. Okay, what did that show us? Interestingly enough, it was not a statistically significant difference. You can see here, this is out to 4 years. However, this was amidst COVID. So if you looked at just pre-COVID, there was a significant benefit in the reduction of heart failure hospitalizations. And I think that that's important for us to keep in mind. And it's 0.75. So it's a robust risk reduction there. So I personally use IV iron in all my patients. I think we'll find out more as time goes on, especially as they interact with SGLT2 inhibitors, et cetera. Okay, now Transform. This was just published last week, I believe, in JAMA. This was looking at the difference in clinical endpoints afforded by the use of torsemide versus furosemide in acute heart failure patients. It was a pragmatic study. It was largely remote monitoring afterwards. And these patients were all hospitalized for acute heart failure and were randomized subsequently to torsemide versus furosemide. And what you can see here is that there was no difference between the two. The rationale was that the torsemide was going to have greater bioavailability, less fibrosis, et cetera, but there was no difference between the two. However, when you just looked at the endpoint of all-cause mortality or hospitalization, there was a hint of a difference, perhaps. But still not statistically significant. When you look at just hospitalizations alone, you can see that there was a very nominal difference in the reduction with torsemide. There was a relative risk reduction of 6%, but again, crossed the lines of unity, and so not statistically significant. So before I go on to that point, I just want to point out one thing here that really struck out to me at this study was, look at the residual risk, meaning look at the area under the curve here that denotes the population's risk of dying over time. And this is just at 15 months. And look at this. You're talking about a 22% mortality, which is really astronomical. Okay, what about the ADVOR study? The addition of acetazolamide that was in the New England Journal several months ago got a lot of attention and press, but yet may or may not have gotten translated into clinical practice, and we could argue as to why or why not that should be the case. But what does this show? So the ADVOR study showed that with the addition of acetazolamide, there was successful decongestion that was more commonly encountered amongst the patients who got the drug versus placebo 3 days after randomization. So these were pretty impressive results. Why? Because though it didn't show a difference in clinical endpoints, we talked about how powerful it is to decongest and how decongestion is associated with better outcomes. And so what this showed is the addition of acetazolamide led to better decongestion. All right, so Rehab HF is a study that's near and dear to my heart. This is about 350 patients, regardless of ejection fraction. They had all been brought into the hospital for acute heart failure. And what the study looked at was the in-hospital initiation of a multi-domained physical therapy regimen versus usual care. And the reason you might say, well, why not do physical therapy for everyone? Of course we do, and we try, but it's not often started that early or intensively as this one was. So the primary outcome was actually the SPPB at 3 months. And we'll talk about that, which is really just a functionality scale, an assessment. And there are other outcomes that were looked at, which included the 6-minute walk distance, the number of criteria for frailty criteria to be fulfilled, the KCCQ score reflecting quality of life, and then the geriatric depression scale, all of which were statistically significantly better or improved by virtue of this early intervention with rehabilitation or physical therapy. So this was a beautiful editorial provided to the main paper written by Stefan Anker, who pointed out the fact that despite the rates of hospitalization and death not being that different between the two groups, perhaps we should not even have expected it to be the case. Rather, we should focus on that quality of life, on that functional capacity and functional standing. Okay, so we've talked a lot about the data here. Let's end with what I think you have the power to influence directly, in addition to those studies, is the power of quadruple medical therapy, the 4 pillars of medical therapy, particularly for heart failure with reduced ejection fraction. And so when you think about the incremental benefit of each of these put together, we need each of the 4 of them on board. And Greg Fonarow likes to use this example, which I think is very good, which is if you had a wild tiger that you had to lock up, you would not lock them up into a 3-sided cage. You would lock them up in a cage that had 4 sides to it so it couldn't get out. Similarly, we cannot let our patients not be on quadruple medical therapy. I do not want us to think about cages in our patients, of course, but it is important for them to be on all 4. So has there been a study that looked at this? Well, of course, the Strong HF study just looked at this. And I thought this was very interesting because it was done with the intention of assessing the rapid uptitration of guideline-directed medical therapy right after a heart failure hospitalization. And what you can see here is those patients in whom it was rapidly up titrated and to target doses, there was an improvement in survival, right? So again, illustrating the point that GDMT matters so, so much. And then when you look at the secondary endpoints, the probability of event-free survival, meaning including other events like pump thrombosis, et cetera, you can see here that the high intensity care group once again did very well compared to usual care. Okay, so it's 8:49 on the dot, and I want to leave some time for questions, but we've gone over everything so far, and I've left a few minutes just to touch on something that's very important to me and our work here at the Journal of Cardiac Failure, which is how much our words matter. So this is a beautiful quote from the Buddha that I like to share, which is, whatever words we utter should be chosen with such care, for people will hear them and be influenced by them for good or for ill. So we set up our conversations about patients in the wrong way. We start out with chief complaints, right? It's inherently negative to hear the word complaint. It's a setup for defensiveness, and it also clouds personalized context and patient priority. But instead, if we went for chief concern, that invokes empathy. It's set up for better patient and physician communication. It invites an understanding of context and priority. This is something I think we should shift to. I certainly have shifted to this in my own practice. The word heart failure itself, gosh, it's inherently negative. It's a setup for fear and anxiety and hopelessness. And it also may have an effect on self-engagement and self-empowerment in care. But rather, if we were like our Canadian colleagues that called it heart function, this is inherently neutral or positive. There is a less emphasis placed on ejection fraction as a result, and more emphasis placed on symptoms and the continuum of heart function across the spectrum of ejection fraction. And it also potentially invites hope, engagement, better clinician communication, and engagement, like I said. And then finally, this word candidacy. We talk about this all the time in heart failure. Do you think so-and-so is a candidate for a given therapy? I think that sounds judgmental, quite frankly. I think it's a setup for opposition or defensiveness. I think it clouds the personalized context that you want for a given patient. So if a given patient, for example, is not deemed to be a candidate for transplantation, they may feel lousy. Okay, well, why not? Is it because of my skin color? Is it because of something else? And so we need to be very, very conscientious about that. So rather, I would argue that we should focus on the benefit derived of therapies. That allows us to focus on the intention of the therapy. It's a setup for better patient communication with their physicians or clinicians. And it allows us to focus on actionable issues. Like, what can we actually do about it? That's what we need to do next. So this is another beautiful schematic. I won't spend too much time on, but this is done by those of you who know Dr. Glockenflecken. His brilliant and talented wife, Lady Glockenflecken, works actually with the Journal of Cardiac Failure as a co-patient editor. And she's written two beautiful pieces that I very much encourage you to take a look at. One, most recently, was called Words to Leave By. And she talks about how she witnessed the cardiac arrest and actually performed CPR on her husband when he had cardiac arrest. And she talks about how the words that she needed escaped her at that time, and what words clinicians and physicians used that helped her kind of come out of her cocoon and her shell to be able to be okay with it and to actually confront herself with it. And, you know, what Lady G does in this is she says, what are the words that explain what happened? Then how do you name it in medical jargon? And then how can you validate that patient's feeling or that loved one's feelings? Really, really important stuff. So with that, I want to leave you with some take-home messages, and we'll have time for questions. One, heart failure is a clinical syndrome, right, with congestion that needs to be proven at this point. Two, decompensated heart failure constitutes a very vulnerable and sentinel event that is marked by worse outcomes. The transition phase starts on admission, not post-discharge. Right when that patient hits the door is when that transition phase starts. And the goals of that, what do they include for the heart failure hospitalization? Well, decongestion, initiation and up titration of guideline-directed medical therapy, referral to rehabilitation, and the consideration of hemodynamic monitoring where appropriate. And finally, I would just urge you to keep in mind that our words matter and how we communicate with our patients and their loved ones really, really matter. And may we all do our best to be sensitive and thoughtful about the words we use when we talk about their care. So with that, I thank you very, very much for your attention. Thank you for inviting me. And I would love to take any questions you might have.
Thank you so much, Doctor, for that wonderful, wonderful lecture and that amazing presentation. I have learned so much in the past 1 hour, and I cannot thank you enough for that. So for our next segment of our keynote, I'll be passing the mic over to our moderator, Gayatri, for the Q&A portion of the session.
Thank you all for coming and welcome to Discussions with Global Leaders. I'm Gayatri Menon and we're excited to be speaking with Dr. Lala, Distinguished Director of Heart Failure Research at Mount Sinai, a phenomenal clinical trialist and a global leader in academic cardiology. We're so excited to have you with us here, Doctor, today. We've received a lot of questions and we'll do our best to get through all of them in the time that we have with you. For the first question, I'm going to be passing the mic back to Muskan.
Hi, Doctor. So my question to you is, with all the latest buzz and all the chat that has been going on about AI, how do you foresee the use of AI in improving the various different aspects of the heart failure patient outcomes? I would really love to hear your thoughts on this.
Yeah, that's a great question, Muskan. I think a lot remains to be seen. There is, you're right, a ton of work being done in this space, both in the acute heart failure hospitalization to predict those patients who will have adverse outcomes, as well as for those patients who are going to get discharged and who will be readmitted, right? And then which patients can we better risk stratify in terms of mortality, et cetera. So it's all work that's being done. AI is interesting, right? Because it gets at nonlinear relationships, right? Things like machine learning are able to do that, which is typical, conventional multivariate analyses and things like that really are talking about linear relationships, but patients are patients, and how psychosocial factors factor in and things like that have not been adequately untangled. And so I think AI will be very, very interesting moving forward. I don't know if it's ready for prime time yet, but there's interesting work coming out to this effect, and I'm very excited about being a part of it.
Thank you so much for that wonderful answer, Doctor. So for the next question, I'll be passing the mic over to Madhuri.
Thank you so much, Doctor, for this wonderful presentation. I truly learned a lot on the heart failure and different workings of it. So my question is that stress is a very potentially modifiable factor, and it plays a very significant role in patients with heart failure, and it can truly change the outcome as well. So how can we address the gaps that can be caused by this? And what are some of the potential pathways that we can take about for this as well?
So I assume you're speaking about mental emotional stress.
Yes.
Yeah, so great question. This is something that's very near to my heart. I think we don't spend enough time on this. We know that the incidence of depression is much higher amongst those patients who have heart failure. We know that stress is a factor, and it has been linked to higher sympathetic tone, right? We know this when we're anxious, our heart rate goes up. And what happens to heart failure patients? Their heart rate goes up. And so this is just a simple example of how important the mind-body connection is. And the AHA actually has a statement to this effect that was issued, I think, a year and a half ago. So I think there's increasing recognition on that mind-body connection. I always emphasize with my patients that in order for their physical health to be better, their mental, emotional, and spiritual health needs to be optimized as well. I think the research in this space is challenging. Just like we saw that rehab HF, I mean, that's functional capacity stuff, right? I mean, it's not necessarily stress reduction, but the endpoints that we're looking at may not be the endpoints that we should be looking at. And so maybe we need to focus more on quality of life.
Definitely. Thank you so much for that, Doctor.
Thank you again, Doctor, for that wonderful, wonderful answer. I really think it's an important aspect, the mind-body connection, and how one patient can actually get better just by believing that they will be. So for the next question, I'm actually going to be asking a question on behalf of Dr. Leifman. So his question is that CardioMEMS is a promising device. However, access may be an issue for lower socioeconomic regions. So How do you think we can rectify this to improve outcomes?
Yeah, so great question. I think things are improving, coverage is improving. Obtaining authorization for it is not as cumbersome as it once was. I think there are more modalities on the market, as to remote monitoring, whether you look at the HeartLogic system with Medtronic devices, or whether you look at now the newer PA sensor monitor devices that are being kind of integrated with AI and other things like the Cordella system, which is under investigation. I think we're going to see an expanded use of these platforms to prevent readmissions. And I think we're going to see expanded ease with which we can have this technology covered. In terms of access, you're right. I mean, right now it's most commonly available at tertiary institutions, but I think the reach is expanding rapidly. I think the main thing really is awareness. If there is an awareness, that hub and spoke model works beautifully with CardioMEMS, where a spoke implants it, but then the hub addresses it, or vice versa. But I think awareness as to these modalities and the fact that they actually do prevent clinical outcomes is crucial in a field where we don't have a lot that does that.
Thank you so much for that answer.
The treatment of chronic heart failure, given that the CONCERT HF trial initiated by the NIH had produced some interesting results. Is it something that you see being extensively used in the future?
So sorry, I missed the first part of your question.
Yes, Doctor. So it was, I just wanted to know what your thoughts were on the use of cellular therapies being used for the treatment of chronic heart failure.
So you mean like stem cell research, basically?
Yes, the MSCs and c-Kit cells, like the CONCERT HF trial. I actually went through it a bit. That was initiated by NIH, and I thought it was extremely interesting.
Yeah, I mean, to that effect, the DREAM HF study was put out, right? We actually conducted a trial looking at LVAD patients and the injection of MPCs, mesenchymal precursor cells, at the time of LVAD implantation to see whether it allowed for increased myocardial recovery, and it was also a negative study. I think the initial smaller phase 2 studies were promising, but when we looked at it on a larger scale, they were disappointing in terms of the outcomes that were looked at. Now, one could argue that the field is not dead in the water because maybe we just haven't found the best way of administering these cells. Should they all be intracoronary? Should they be systemic? Should they be intramyocardial, right? We don't know the optimal delivery for them, and we also don't know the optimal environments for them. Is it too far gone with heart failure? There's a lot to be understood in terms of ischemics versus non-ischemics as well. And so I think as it stands today, we've had a few randomized controlled trials that have failed to show efficacy of mesenchymal precursor cells. And then to that effect, also gene therapy has been completely negative, right, with the Cupid follow-up studies. And so I think I don't like to say never. And kudos to the scientists and clinicians who pursue this investigation, but I don't think it's applicable clinically at this moment.
Thank you so much, Doctor, for that answer. Definitely, I think we all should be hopeful, but like you've said, hopefully research might pop up in the future. You never know. So with that, I'd like to pass the mic over to Sean for the next question.
Thank you, Dr. Lala-Trindade. This talk was fantastic. I'm a third-year medical student myself, so I've been seeing a lot of heart failure patients in the hospital I'm working at. And it's tough seeing what they go through. And, I really appreciated what you said about instead of chief complaint, switching to chief concern. I will certainly be using that from now. But my question here is, with the need for improved health literacy, and I'm happy you touched on that, and the quality of life improvements associated with patient-reported understanding, as you mentioned, what role do you think local healthcare systems, like hospital systems or even outpatient clinics, what role do you think they can play in educating their local populations about common diseases like heart failure? And what tools do you think they can leverage in today's social media world? Thank you.
Yeah, thank you so much. I think you mean, I think if I understand your question correctly, is like what broader systems can hospital systems leverage to improve outcomes? Am I understanding that correctly?
Yeah, that's a way to interpret it. That's exactly right.
Yeah, I mean, I think there's a lot of things that I have thoughts on for this. I think, taking advantage of AI platforms to not consolidate, but to allow for streamlined care in heart failure across hospital systems is a really, really important thing that we haven't gotten a handle on yet. So I think streamlining care is important. I think getting better at recognizing who needs an escalation in care versus not is important. And there are some risk score models, but what we need to do is be able to look at our own internal populations and say, okay, how is this patient going to be at higher risk than another patient? And then be able to triage them appropriately, both in hospital and then subsequently for follow-up. So I think there's a lot that can be done. I think with EHR I think there's more for us to leverage with EHR, to tell you the truth. And unfortunately, we find ourselves more kind of bogged down with note writing, et cetera. But what we really, I think, could use it for is to ensure perfect communication, or not perfect, but at least excellent communication across hospitals within a system, or even outside of the system for that matter. And then getting better at risk prediction as to who needs follow-up with whom, when, and how. And then I think that intra-disciplinary as well as multidisciplinary coordination of care is also super crucial. And I think there's a lot of dialogue about whether the metric of 30-day rehospitalizations is appropriate or not. I think there have been, Karen Joint has written a lot about this, and JAMA and other areas, as well as many other people, Ashish Jha, et cetera, where that might not be the right metric, and instead we're getting penalized. And so I think we need to think about payment models being very different for how we care for heart failure patients to improve their care.
Thank you so much, Doctor, for that amazing answer. For the next question, I'll be passing the mic over to Victoria.
Hi, everyone. Hi, Doctor. It's been a pleasure to be here. I learned a lot with you tonight, so I'm very thankful for that. My question is regarding the treatment with renal patients. Is SGLT2 inhibitors a safe drug to be used in renal patients?
Great question. So yes, in fact, I think what we've seen is the studies looking at SGLT2 inhibitors specifically for the improvement of renal outcomes is actually incredibly impressive, just almost as impressive as their beneficial effects on the heart. And so I am incredibly liberal about the use of SGLT2 inhibitors across the spectrum of ejection fraction, across settings of chronic and acute heart failure, and across the spectrum of GFR. I mean, labels are different slightly based on GFR less than 25 and GFR less than 20, but quite frankly, I think if you look at even the lowest GFR groups, they benefit from SGLT2 inhibitors, not only from a cardiovascular standpoint, but from the renal standpoint as well.
Thank you so much, Doctor. That was an amazing answer, and research is truly amazing when you think about it. This presentation was really great. For the next question, I'm going to be passing the mic over to Pallavi.
Hello, Doctor. Thank you so much for this amazing presentation tonight.
So I have been quite intrigued by the way you mentioned about drugs and the way how the latest developments have been in the uh, in the field of cardiology, especially. It's quite astonishing. Um, how do you so can you hear me? I'm audible. I'm sorry.
Yeah, no, I can.
Yeah, Pallavi, you're audible. Go ahead. Yeah. Second. Yeah. So, what, according to you, how do you think has cardiology, impacted your life? Like, how did you get inspired by cardiology to, I'm sorry. Just a minute.
I think I got your question, which is what, more of a personal one, which is what is it that attracted me to cardiology? My father is a cardiologist. I witnessed my grandmother having a heart attack when she was visiting us from India when I was a young girl. And that really stayed with me. And the way my father took care of her at home really, really impacted me. And I love the fact that the heart is the center of circulation for the entire body, but also, your heart center is also the center for your emotional and spiritual well-being. And so I think, I just love the fact that they are connected, as we talked about earlier. I love the fact that the heart has so many different aspects to it, the pumping aspect, the physics that is incorporated, the electrical aspects that are incorporated, the flow mechanics and fluid mechanics that are incorporated. I just think there's no end to how amazing it is to marvel at the cardiovascular system. So that's why I went into it. I didn't necessarily know that I was always going to do this, but I can't say there's a day that goes by that I even think twice about having done anything else.
Thank you so much, Dr. Lala. You're truly an inspiration for all of us here and for all the junior trainees as well. Thank you so much for spending this time with us today. And the presentation was amazing, and we truly learned a lot.
Well, thank you so much for having me.
Thank you so much, Doctor, for that amazing, amazing presentation and that wonderful Q&A portion.
Amazing session.
Thank you so much. We really appreciate you coming.
My pleasure. Thank you